We're going to hit this in 5 quick steps. First step, surgical blades and safe handling. Second, making the perfect incision. Third, monopolar versus bipolar cautery. Fourth, advanced energy and sealing. And finally, specialized ablation technologies.
All right, part 1, surgical blades and safe handling.
This right here is the absolute foundation of the surgeon's toolkit. Long before lasers or ultrasonic waves ever come into play, it all starts with a simple, perfectly sharpened piece of steel mounted on a barred Parker handle. Let's rapid fire through exactly which blade does what. We have the number 11 blade. This is your pointed stab blade. You use it for the incision and drainage of an abscess or an arteriotomy. Then you've got the curved number 12 blade, which is specifically designed for suture removal. And for your standard incisions, you're grabbing the number 10, 15, or the 20 to 23 blades. And this brings up a really crucial pearl of wisdom. Look at the curve on those incision blades. That curved portion is called the belly. And contrary to what you might naturally assume, it's actually the belly that is the sharpest portion of the blade, not the tip. So, how do you handle these incredibly sharp tools? Safety is absolutely paramount for both the patient and the staff. First off, you never, ever mount a blade with your fingers. You use a mosquito forceps to attach it to the handle. Once it's mounted, you hold it like a pen, or sometimes palmed. But listen, here is the strict golden rule of surgical etiquette. You must always pass the blade via a kidney tray to avoid a sharp injury. And if a tray absolutely isn't available, you have to pass it with a pointed end facing yourself. Seriously, even if you are handing the scalpel to your worst enemy, that sharp point stays aimed right at you. Moving right along to part 2, making the perfect incision. Okay, you've got the tools safely in hand. Now it's time to actually put that blade to the skin. And the technique here has to be literally flawless to get that masterpiece cut. First, the angle of the blade has to be exactly perpendicular to the skin. Otherwise, you're going to end up with these undermined, beveled, ugly edges. The direction of the cut is always from far to near, meaning opposite side to same side. So think about it. A left-handed surgeon actually cuts from their right over to their left. It is all about total control. We also have to respect what are called Langer's lines. By cutting parallel to these dermal collagen fibers, the wound heals so much better with a beautiful minimal scar. And above all else, anatomy is king. You have to be hyper-aware of vital structures hiding just beneath the surface, like, say, protecting the facial nerve when working on the parotid gland. Part 3, monopolar versus bipolar cautery. Now let's see how this all builds together. Once that perfect cut is made, the inevitable happens. Bleeding begins. And this is exactly where we pivot our narrative from cold steel to our foundational energy sources. Let's unpack the classic monopolar cautery, often called the booby tip. It looks just like a little plastic pencil with 2 distinct buttons. If the surgeon presses the yellow button, it activates the cutting mode. This uses a low-voltage, continuous waveform that literally explodes the cell's water into steam to slice through the tissue. But if they press the blue button, it switches to coagulation mode. This relies on a high-voltage alternating current that dehydrates and denatures proteins to stop the bleeding. There's also fulguration for even deeper coagulation using the highest voltage, and a blend mode that uses a combined waveform so you can cut and coagulate simultaneously. Hold on, we actually need to hit pause on our fast pace for a really stark reality check. Warning, cautery sources are the single most common cause of operating theater-related fires. When you're wielding high-voltage electrical currents in a highly oxygen-rich environment, safety protocols absolutely cannot be ignored for even a fraction of a second. Now, what's really interesting about this next part is the heavy contrast between monopolar and bipolar cautery. Monopolar requires a large, well-vascularized grounding pad on the patient's thigh or calf to safely complete the electrical circuit. If that pad is missing or even just too small, all that electrical current channels into a tiny area, causing severe, devastating burns. Monopolar also risks lateral current spread to vital nerves. And it is incredibly dangerous for patients with pacemakers or when working on narrow end arteries, like in penile or ear surgeries, because the current can channel straight down and burn the entire base. No thanks. Bipolar cautery, on the other hand, looks like a pair of tweezers or prongs. The current simply passes from one prong to the other. That means no grounding pad is needed whatsoever, and there is zero lateral current spread. It's completely safe near vital nerves, pacemakers, and narrow pedicles. The only limitation? Bipolar can only coagulate. It cannot cut. Which brings us to part 4, advanced energy and sealing. Fast forward a bit. Modern surgery requires smart, high-tech energy solutions that completely bypass the limitations of basic electrical cautery. We've officially entered the era of smart surgical tools. Take a look at the incredible mechanical sequence of the ligature device. This tool uses a really sophisticated combination of heat and physical pressure. Step 1. You clamp down on a vessel. And incredibly, this thing can handle vessels up to 7 millimeters in diameter. Step 2. The device applies precise heat and pressure to literally denature the body's own collagen and elastin. Step 3 is pure innovation. You simply wait for the device's audio feedback. It gives this little beep to tell the surgeon a perfectly precise seal has been formed. And finally, step 4, you just safely cut the perfectly sealed vessel.
And the tech just keeps getting better. Let's rapid-fire compare these advanced tools. The harmonic scalpel is fascinating because it works purely on ultrasonic oscillation, literally vibrating the blade between 20 and 50,000 hertz. Because there is absolutely zero heat produced, it is highly precise in your vital structures and effortlessly cuts right through dense scar tissue. But what if you want the best of both worlds? Enter the Thunderbeat S. This hybrid device brilliantly combines the ultrasonic cutting of the harmonic with the advanced heat and pressure sealing of the ligature. A surgeon can instantly switch between the two modes right there on the actual instrument.
Then you have the CUSA, the Cavity Ultrasonic Aspirator. This device is an absolute game changer, especially for complex liver surgeries. It uses oscillatory fragmentation to selectively destroy cells that have a high water and low collagen content, like hepatocytes in the liver, while simultaneously aspirating or vacuuming up the debris. It perfectly isolates the tougher blood vessels without damaging them, making it the ultimate tool for non-cirrhotic liver resections. All right, final section, part 5, specialized ablation technologies. We've reached the final tier of the surgeon's toolkit. These are instruments used not just for cutting or sealing, but for completely obliterating large areas of diseased tissue, like deep tumors. Here we contrast two really heavy-hitting ablation techniques. First up, radiofrequency ablation, or RFA. This uses a high-frequency alternating current, and it does require a grounding pad, much like monopolar cautery. It's highly effective for ablating liver tumors up to 3 centimeters in size. However, microwave ablation is rapidly replacing RFA in many modern centers. Why is that? Well, because it uses oscillation and frictional heat, meaning no grounding pad is required at all. It's significantly faster, treats a much larger area, and creates a far more homogeneous zone of cellular destruction. So the crucial point here is knowing exactly when and where to use these powerful tools. Take argon beam photocoagulation, or APC. It uses a literal beam of argon gas to conduct the energy. Its massive advantage is its incredibly fast, very shallow penetration, which makes it ideal for treating really delicate areas like Barrett's esophagus or superficial GI bleeds without perforating the underlying tissue. But the disadvantage, it is completely ineffective on large vessels. And please, pay close attention to the extreme danger here. You must absolutely avoid using APC anywhere near central veins. If that argon gas gets into a major vein, it doesn't dissolve in the blood, which can lead to a massive, potentially fatal gas embolism.